Oh, hello, dear colleagues. My name is Gerd Wurmesser, and I'm talking to you from the sunny Berlin. It's a beautiful day, and it's a great pleasure for me to introduce to you Professor Maurizio Cutolo, who's actually a very good friend of mine. And so I will say a few words later on, and it's a great pleasure to moderate this webinar today. I will just start to open up my introductory slide. And okay. So the title, which I think is really exciting, is the optimization of glucocorticoid therapy for long-term treatments in connective tissue diseases. And I think it couldn't be a better time because we are celebrating the 75th anniversary of the discovery of the glucocorticoids. And despite all the pros and cons that we're discussing, they are really a mainstay of treatment in rheumatic diseases and many, many other diseases. And they are really the development of modern treatment in rheumatology altogether. And so my name is Gerd Wurmesser, and I'm a member of the steering committee of the ERN Reconnect Network, which I think is a very important reference network funded by the European Commission. And we are dealing with rare diseases, especially systemic diseases in autoimmune rheumatological diseases. And the speaker today is Professor Maurizio Cutolo, who is the working group leader in this area. So the optimization of glucocorticoid therapy for long-term treatment in CTDs is our current practice and a theme. And on the right-hand side, I'm just showing you the picture of Philip Showalter Hensch, who won the Nobel Prize with the discovery of the glucocorticoids together with two other colleagues. You see the molecule in the center. And he is so far the only rheumatologist who ever got the Nobel Prize. Obviously, we're all working very hard in rheumatology that we will get more. As you know, many Nobel Prizes are related to clinical immunology, to immunology as a whole, to cytokines and so on. So that, of course, many discoveries in immunology and in related disciplines, including rheumatology, were also awarded for achievements in these areas. So let me please introduce to you Maurizio Cutolo. Professor Maurizio Cutolo is a professor of rheumatology and internal medicine at the Laboratories of Experimental Rheumatology and Academic Division of Clinical Rheumatology, Postgraduate School of Rheumatology in, I must say, the beautiful city of Genoa. He's at the university there. In Italy, I have paid several visits to this beautiful city, and it's always worth going there. Maurizio is the former president of the European Alliance of Associations for Rheumatology, EULAR, in 2013 and 2015. And I'm very happy to tell you that he trained me because I was his successor as the president of EULAR for the next 2 years. And during his presidency for EULAR, he was also the president of the International League of Associations for Rheumatology, ILAR. And for today's purpose, he's the advisor of the EULAR Education Committee and member of the Scientific Advisory Board of the Autoimmune Association. And very importantly, he serves as deputy chair of the European Commission Network on Rare and Complex Connective Tissue Diseases, RE-Connect, ERN, and is the co-chair of the working group on education and training. So some technical notes. The webinar will be recorded and published on the RE-Connect's website. You can see the link here and on a YouTube channel. And please, for the questions during the webinar, use the questions and answer session in the Zoom black bar or just use the chat. And we will then address these questions to Professor Cutolo after the presentation so that we do not interrupt the presentation and have a very nice flow of this very important contribution. So thank you, Maurizio, for joining us today. And obviously, with this exciting subject, we are really looking forward to your webinar. So Maurizio, please go ahead. Thank you very much for coming today.
Thank you very much, Gerd, for this generous presentation and introduction. And so I now try to start with my presentation that is exactly what Professor Boom announced. So the optimization, how today we have started to optimize the use of glucocorticoids. We can say that one very interesting part of the earliest story of the glucocorticoids and are in some way some forgotten episodes related to the real history of glucocorticoids started in 1930 when the chemist, the Professor Kendall, started to study some hormones extracted from the corticoadrenal glands, bovine corticoadrenal glands. He identified some compounds that call from E to F. 4 compounds were the most interesting for this, and in particular, the compound A and the compound E that were, now we know, the dihydrocorticosterone and cortisol. But what happened at the same time? At the same time, during that World War, a rumor reached the United States and UK especially that Germany were successfully using some extra hormone from the adrenal gland, bovine adrenal gland, and give this to the pilot of Luftwaffe in order to obtain a better performance to the high altitude. These glands were transported by U-boats from the Argentina to Germany. And here, clearly, the labs in US and UK started to see which kind of product were and restarted very strongly the interest for the compound E and E. In fact, in 1942, a chemist working again in the lab of Kendall isolated, and once isolated, started the production, the industrial production. And finally, in 1948, after a few years, the first patient with rheumatoid arthritis was started with the compound. And the 3 researchers, Hensch, Kendall, and Rechstein, obtained the Nobel Prize in 1950. But today is the time to send and to expect the retirement of glucocorticoids or an optimization. Well, we can say that from 1950, when the glucocorticoids were introduced up to today, they are always associated with the new drugs for the treatment of connective tissue disease, or in any case, as disease-modifying anti-rheumatic drugs. So it's clear that it's a fundamental way to approach the anti-inflammatory and partially the immunosuppressive activity. But which is the role of glucocorticoids in the pathophysiology of chronic immune-mediated rheumatic disease? Well, it's clear that we have our own production in our body, in the adrenal gland. Cortisol is produced during the night. So these products is in our body and follow a rhythm of production. The same rhythm for inflammation is again the night. So the inflammatory reaction in particular is strong during the night. Cells are activated, growth factors are released, proliferation of cells and production of cytokines. They are responsible during the night for the strong immune inflammatory reaction, and in the morning, the majority of such kind of disease express the clinical symptoms with pain, stiffness, and so on and so on. So there is a rhythm of inflammation, and there is a rhythm on the production of endogenous cortisol. that has an anti-inflammatory and immunosuppressive activity. So in chronic condition, we are discussing long-term chronic disease. The adrenal gland are not anymore capable to produce the amount of endogenous cortisol that is necessary. In particular, the product of the cortex of the adrenal gland, and here we include cortisol, corticosterone, and cortisol, are deficient. And here, the high value of the exogenous administration of glucocorticoids are hormones like a replacement hormonal therapy. This is the basis for the long-term replacement therapy with possibly low dose. But the clinical efficacy of low dose of glucocorticoids in rheumatoid arthritis as an example of chronic immune-mediated connective tissue disease, it's very clear. And from many years, it's clear that glucocorticoids exert a sort of disease-modifying activity, slowing the radiographic progression at least in 50% when given to patients, especially at the beginning of a disease. And the effect, it's for a long time and a very strong genomic effect. We can say also epigenomic effect through the epigenetic interaction. In fact, glucocorticoids interact with receptors, move inside the cells and interact with the nuclei and modify the production of regulatory proteins through the transactivation of pro-inflammatory, decreasing the action of pro-inflammatory genes and so proteins. So there is a classical epigenetic action interacting with the genes. So it's clear that long-term low dose has a clear basis to be considered. And here, for example, some studies that showed the clinical value of low-dose prednisone in rheumatoid arthritis, especially on damage of the joints, but also on the, we will see better how it helps in the remission together with classical, conventional, or biological disease modifying. And here you can see over the time how the addiction of prednisolone 7.5 milligrams plus the DMARD versus the DMARD alone improve the percentage of patient remissions. And this is a very important aspect, especially, and we will see regarding the side effect, when the doses are around 7 or less than 7. We can say, for example, with conventional anti-disease modifying like methotrexate, that today is still a gold standard for conventional, how the addiction of glucocorticoid to methotrexate increase the duration of the efficacy of the therapy, as well as reduce the side effects of methotrexate. And so this combination that we will see is suggested at the beginning of a treatment following the guideline of Euler, this combination of low-dose glucocorticoids plus conventional, especially methotrexate, when tolerated, is the best way to approach to ensure some result and for the duration of such approach over the months. We can say that especially on inhibition or radiographic progression, when is started such combination, these effects, positive effects, may be extended over years. And so it's clear that from several studies, all the study of combination, for example, sulfasalazine alone or plus glucocorticoids, the indexes of radiographic damage of the joints decrease. This is a very important aspect. If we look at the Euler guideline over the last 10 years regarding the treatment and the use of glucocorticoids in rheumatoid arthritis, especially at the beginning, when we say low dose, and this is what's published at the end of a working group on glucocorticoids, low dose usually means a daily dose of less than 7.5 per day. So let's see, 10 years ago, when were published the data, the combination of methotrexate or other conventional systemic DMARDs was suggested in combination with short-term and low-dose glucocorticoids. Of course, in case of contraindication for methotrexate, to be used other conventional, like leflunomide and so on. At that time, 10 years ago, was suggested short-term low dosage. After some years, in 2017, again, this was the formula for the beginning of treatment in early rheumatoid arthritis. But the terminology low dosage was less considered, short terms, but a little more freedom to adjust the dosage. And this was again suggested in 2019, always combine short-term glucocorticoids and reduce as soon as possible with conventional DMARDs, up to the last presentation of the guideline for the treatment of rheumatoid arthritis, short-term and reduce as rapid as possible. We should say now that short-term, in any case, from many evidence, still the best way to start the combination, at least in rheumatoid arthritis. We will see also and mention other connective tissue diseases, but usually, at least this is the way to approach. What about the use of glucocorticoids in Europe, in top 5 EU countries? We can say that 85% of glucocorticoids are, in any case today, used at the dosage less than 10 milligrams. And the percentage of treatment with less than 5 milligrams is increasing. And at least 70% of rheumatoid arthritis patients have been treated with glucocorticoids, even more. So we can say that still the need to add glucocorticoids to conventional, even new small molecules. In this review from one center in the United States, 300 patients were evaluated and was evaluated the use of glucocorticoids over a large period of 25 years. And it was evident that over the years, the dosage was reduced and reduced over the time from 10, from the beginning, to 3.6. And even the number of patients that started with less than 5 milligrams was increased over the years. This is an important aspect because it's adjoining also to the introduction of methotrexate as a sparing drug for the use of glucocorticoids. And if you look at the same time, increased over 25 years the use of methotrexate from 10 to 78%. And we know that methotrexate exerts also strong anti-proliferative, anti-inflammatory action. So in few words, it's quite clear that the combination in several connective tissue diseases, I can say, of anti-proliferative drugs, especially methotrexate, and low-dose glucocorticoids is absolutely a background that should be considered more and more as an optimization of the use of glucocorticoids obtained on the field from the evidence, from the daily evidence. But what about the adverse events of low dose? Are so severe as in the past? Well, if we consider prednisone dose less than 5 milligrams, you can see that at least for years, we are very close to the no prednisone treatment. So this is really a replacement therapy that in subjects lacking the endogenous glucocorticoids is a sort of replacement hormone, like insulin in diabetes. And so it's clear that over the time should be reduced, of course, the dosage, especially when started remission. But we can say that relative risk of non-vertebral, for example, fractures, is very low if we look at the low dosage of 5 milligrams. Of course, increasing the dosage, the risk increase. Other side effects like chemosis, glaucoma are all dose related, even if we stay, especially if we stay under 7.5, but over 7.5 for sure start the side effects. And we can see here, for example, the medium to long-term glucocorticoid therapy in rheumatoid arthritis with low dose, a mean dose of 6.5 is, you can see that almost it's similar when compared to the placebo. And this is very important because tell us that we are doing a real hormone replacement therapy, especially during the first time. This important ESPOIR study evaluated 600 patients with rheumatoid arthritis from the early arthritis, and was observed that when the dosage is adjusted to very low dose, around 3 plus or minus 3, at that time, and for a long time, you can see 1,000 days, here the rate of side effects without glucocorticoids, with glucocorticoid, was, from the statistical point of view, over 7 years analysis, was absolutely not significant. And this is really important because tell us that the benefits when we use for a long time low dosages, it's absolutely minimal, the increase of side effects, classical side effects. So in the result of this task force showed that when you consider dosage less than 5 milligrams a day, the benefits are over the risk in the majority of patients. When we consider dosage over 10, the benefits are less than risk in terms of side effects, and in the majority of patients. This is a very important subdivision of benefit-risk ratio based on the daily dosage. We should say another important aspect. What about the safety? If we consider the first study, that is the Gloria study, considering the low dose on prednisolone in patients with rheumatoid arthritis aged over 65, so with a lot of comorbidities. And this is I will present the result of the first randomized, double-blind, placebo-controlled study using the glucocorticoids supported by European Commission during the Horizon program. And here the most important questions. The concomitant use of glucocorticoids, the low dose, increase or not the therapeutic success, and the safety is altered with so long for 2 years of continuous administration in patients over 65, with all their comorbidity staying, their comorbidity. And 451 patients from 7 European countries were considered, and 80% of them were still on their standard disease-modifying treatment. So no changes or their treatment, just adding in 50% prednisone, 5 milligrams, prednisolone, 5 milligrams a day, versus not addiction. You can see the ongoing disease-modifying drugs, conventional, biological, all of them still going. Comorbidities were including all the comorbidities more frequent in 65 years, over 65 each. The results were very interesting, were very high statistical significance, even if only of 0.37 point, the DAS activity was lower in patients with prednisone. But what is important, that the joint damage progression, even in patients with still ongoing rheumatoid arthritis, not early arthritis, as we mentioned, they are the best candidate for the low-dose glucocorticoid at the beginning. 1.7 points were lower with a statistical significance. This is a very interesting result because tell us that even in patients with high risk, the addiction of glucocorticoids, low dose, 5 milligrams, still reducing the joint damage progression, and thus 28 improvement. Of course, 60% versus 49% experienced the harm outcome, but was not high risk and high adverse events, excluding the infection, the risk of infection. And the discontinuation for adverse events for both around 40% in active disease, and others, especially remember this study was running during the COVID period, so unfortunately several patients were to stop the treatment, 19 versus 21%. COVID unfortunately was a problem for everyone, and this was one of the unfortunately adverse events due to the time, the COVID presence. In conclusion, was very interesting to observe that this very serious double-blind, placebo-controlled randomized study showed for the first time the superiority, or in any case, the efficacy and the low rate of serious side effects over 2 years of treatment, even much lower than the estimated from observational studies that sometimes are not so strict like when you do such kind of controlled study. We can say another thing more recently, that after 2 years of successful treatment, the tapering and the stopping of the blinded study medication 3 months was efficient. And 191 patients on the Glorious study were eligible, and flares occur in 45% of patients treated with prednisolone versus 33% treated in patients with placebo, not significant difference. And the tapering of prednisolone increased a little the disease activity to the level of the placebo group, without, and this is a very important, signals of inhibition of the HPA. So without any signal of adrenal inhibition for the feedback of the administration, exogenous administration. So suggested that the withdrawal of low-dose prednisolone in a period of 3 months after 2 years of treatment is feasible. But what the real optimization was already achieved years ago with low doses for long-term in rheumatoid arthritis, polymyalgia rheumatica, all studies are published. Usually, the way to administer low dose is early in the morning, but this is too late if you want to optimize the action, the anti-inflammatory action. Why? Because during the night, we already explained that the inflammatory activity starts around 2 or 3 o'clock. So the modified release prednisone obtained this result without waking up the patient in the middle of the night, as I used to do for years. This drug is, this prednisone modified release is administered at 10 p.m. and after 3-4 hour release the content and start the action. And in the morning, you can see here in this Lancet paper by Frank Buchtereit, first author, when you control after 3 months the immediate release prednisone versus modified release prednisone, looking at the morning stiffness as a major clinical symptom of rheumatoid arthritis, the significant difference. And when the control group was switched to modified release, you see again a dramatic improvement in the symptomatology in early morning. So this study confirmed that the best time, the optimized time for the administration, low dose, long-term, is during the night. So we can conclude that low-dose glucocorticoids are essential in connective tissue disease, several connective tissue diseases, especially in rheumatoid arthritis, and act physiologically as a replacement therapy, an adjuvant of the disease-modifying conventional or biological drugs. The side effects following the GLORIA study for long-term, even in patients at high risk, depend from the presence and intensity of their high risk, but can be followed, modified, anticipated. The GLORIA showed that in a double-blind, placebo-controlled randomized study, that this treatment, even in senior patients at higher risk, should be done with improvements, and the withdrawal of low dose after 2 years and in 3 months is feasible, and the use of possibly night release of the low dose for long term achieved the best epigenetic modification of the genomic activation during the night. In other words, the gene activation involved in an immune inflammatory reaction. So thank you to all of you. Let me thank our group in Genova, and especially Reconnect, that is our dome, and Euler, that is the biggest dome that helped us during this continued updating. Thank you to Gerd also for his moderation.
So thank you very much, Maurizio Posacutulo, for this marvelous lecture. And so I think now it's time to discuss it. And again, I would like to reiterate, please put your questions into the chat or in the question and answer box at the bottom of the Zoom screen. And one question came in by Professor Vanessa Smith, and she asked you, thank you very much for a very nice lecture. And you alluded a little bit to it, but what dose of prednisolone is safe to give continuously over time to patients without augmenting the risk of osteoporosis?
Yep, this is a very good question, because as we mentioned, the risk of fracture over long time treatment is one of the most dramatic problems together others, but it's clear. So we know from the literature that usually less than 7.5, it's a situation that reduce dramatically the risk of fracture over the time. But it's now suggested, when we start the treatment with glucocorticoid, even 5 milligrams, to add vitamin D, and usually such kind of patient have low dosage, low amount of vitamin D that is important for the calcium absorption. And if the patient started already in a risk condition, so with already signals of bone reduced density, maybe the addiction of bisphosphonates, not in a very strong amount, but as prevention of possible increased risk or a decrease of bone density should be done. In other words, the best suggestion is when you have to start the treatment with glucocorticoid, especially after the menopause in elderly, the combination with vitamin D, evaluation of parathyroid hormone levels, calcium, and the bone mineral density, and anticipate the decrease of the bone insufficiency is the best way to start safe the treatment. Thank you.
So in general, Maurizio, you would recommend a bone densitometry in elderly patients, especially in order to avoid or in order to deal with this particular problem. And I think that's also what I do in daily clinical practice. If I anticipate that glucocorticoids will be needed for an extended period of time, I always do so. So some other questions came in, and Maurizio, some people may question, say, okay, glucocorticoids are nice, especially in rheumatoid arthritis in the beginning as adjunct treatment. And of course, it's highly economic because glucocorticoids are really very inexpensive. I think this is also a very important aspect. But increasingly, the biologics are also getting less and less expensive. So how do you envision the future? Let's say starting rheumatoid arthritis treatment, will we maybe start with biologics rather than glucocorticoids, or will glucocorticoids still have their place, as you already mentioned?
Yes, this is a very nice question, and I can only answer based on the experience of the last 50 years, or even less, 20 years, when the new biologicals and small molecules have been introduced. The problem is that if we approach the immune inflammatory reaction with a washout, for example, of important mediators of the inflammatory reaction, like cytokines, and we use monoclonal antibodies, of course, we wash out, but we don't block the production, or reduce, but we don't block the cells that are engaged. If we use the drugs that block the costimulatory molecules, or we try to block B cells or macrophages with CTLI4 Ig that blocks the costimulatory molecules, or other rituximab way to block the B cells, again, we block, can I say, some of the components of the complex family of cells involved. So we still a little focused in the producer, the cell produce the mediators, but still in a little detailed approach. If we use the blockers of intracellular signals, so from the product to the cell, to the intracellular signal with kinase inhibitors, we have more than 400 kinase inhibitors in the cells. Here, of course, the action is direct, but sometimes we observe recently several side effects because kinases serve several functions, not just the transduction of the signal for the production of cytokines or immune inflammatory products, but also are involved in several cytokines that defend from infection, in action of the cells in the cardiovascular system, and so on. So in few words, glucocorticoids on the other side, of course, there are more than 4 times genes sensitive to the glucocorticoids in the chromosome, but are activated during the day in a circadian way, in circadian rhythm, under request. And during the night, especially, are activated the genes involved in the protection in normal condition when you have your endogenous cortisol to reduce the every daily insult can generate inflammation or allergy or cancer or so on. So from this point of view, when we use glucocorticoids in low dose, we replace what in chronic stressing condition in any case is lacking. So it's also correct sometimes to dose the cortisol levels in early in the morning to have a complete vision of the endocrinological status of the patient with chronic immune-mediated inflammatory reaction. So I believe that forever, low dose, short-term is necessary, but low-dose glucocorticoids will stay for long because they are a sort of background downregulator of the complex mechanisms that are the basis for the activity of the single clones of cells involved in the production of mediator, interaction, activation of the cells, cloning, and so on. So that is why I believe this is a concept of neuroendocrine immunology. So endocrine, the control of cortisol is natural in normal condition, but is lacking in stress. And we know very well, like, for example, in polymyalgia rheumatic elderly patients, usually the beginning of the disease starts after strong stress when they are reduced their capability to react to any inflammation, infection, or so on.
Thank you very much, Maurizio. If I summarize it correctly, the prednisone dose below 5% appears very safe. So also Frank Burkhardt worked on it as well. And so there is not really major weight gain, high blood pressure. You mentioned the eye involvement and so on. But what remains are, surprisingly to me, are the infections. Because how with that little amount of glucocorticoids, let's say 3 milligrams per day, what is the mechanism behind it that there may be more infections in these patients?
No. This is a very interesting aspect because we know that when we treat with glucocorticoids, we observe neutrophilia. So increase the number of white blood cells in the blood. This is also a way to control that the patient is using glucocorticoids sometimes because they increase the number of white blood cells, neutrophil in particular. Why? And also platelet. Why? Piastrino thrombophilia. Why? Because there is, during the inflammatory reaction in the area, a request of cells that may intervene against the infection, maybe neutrophils and other cells. So it's clear that in this case, if I downregulate the action on neutrophils of M1 macrophages of innate immunity, I can reduce this natural migration of immune inflammatory cells in the blood to move to the area where they need. And in this case, of course, we reduce the efficacy of the endogenous system to downregulate the infection, to try to block the infection and the infection growth. Especially if I use the glucocorticoids locally, for example, in the eyes, and there is an infection, I make a disaster. Or in a situation you have a wound and you have an infection and you add the steroids to reduce locally the inflammation. So this action that reduce the intervention of immune inflammatory cells in case of immune inflammatory mediated disease, of course, is a damage in case of infection, because reduce also the protection against the infectious bacteria and so on.
So thank you very much, Maurizio. The final question I have on my list here is how much prednisone do we really need? So we observed in the Semira trial that when most of the flares, and in some patients we had it when we discontinued, occurred when we really went from 1 milligram to 0. I mean, it was not formally designed to look at this, but no. when you look at the data, many colleagues ask you, well, maybe this 1 milligram is enough. It appears to be a tiny amount. What is your opinion?
Thank you for this question, because it is very fascinating. In my experience over many years, I understood that for each of us, there is a threshold of need, of minimum glucocorticoids reserve or amount to contrast minimal events that need endogenous immune inflammatory, anti-inflammatory action. In other words, I see, and I agree with you, that some patient can stay for very long with 1 milligram up to 3 milligrams without any problem, but positive or negative problems. But when they decide that is the case to block by themselves, frequently they come back to us and they say, oh, I'm sorry, I feel some pain. It's at the beginning, but I don't want to come back to the past. So that means, in my opinion, that there is a minimal threshold for each one that is at risk of inflammation or is a survivor to a strong immune disease, that we should try to keep this. Because this, it's some safety threshold to avoid that for minimum stress or infection restart, and the population of immune inflammatory cells has a free green light to start in short.
So thank you very much again, Maurizio, for this marvelous and exciting lecture. And I think the glucocorticoids, even after 75 years, are still full of riddles and, of course, initiating a lot of new and exciting research in the future. Obviously, we will have additional drugs, and we already have them. So we will find the place for the glucocorticoids in these areas. So I think this will be extremely interesting, and also the circadian rhythms and the development of potentially new glucocorticoid moieties is very exciting. So I promise to the listeners of today's presentation that very likely in the future we will have additional new exciting data on the subject of glucocorticoids even after 75 years. So I wish to thank you a lot, Maurizio, also on behalf of the RE Connect network. Would like to thank the European Commission for having made all this possible, obviously. And I would like to thank the audience and the technical support of this webinar for the great support. And again, it will be possible to see this lecture in about a week from now on the YouTube channel. You will find all the details in the chat. And with these words, I thank everyone a lot and wish you a very nice evening and late afternoon. Thank you very much for joining us. Bye-bye.
Thank you, Gerd. Thank you, Emanuele.